Thank you, ma'am. Thank you, sir. So moving on to the next session is a reverse panel with the sir himself. So I call upon Dr. Kritika Devi, ma'am, to the stage. She is a senior consultant in Nova IVF Fertility, MRC Nagar. She finished her MBBS in Madras Medical College. She finished her MSOG in JIPMER and she did her fellowship in fertility in Chettinad Hospital. She did her observership in Gleneagles Hospital, Singapore and Bangalore Assisted Conception Center. She is a president in International Fertility Research Foundation and she is the author of the chapter titled Frozen Embryo Transfer Protocols for the Handbook on Ovarian Stimulation, and she is present in various national and international conferences. May I call Dr. Kritika Devi ma'am to come to the dais. The next speaker, Dr. Divya Narasimhan ma'am. She is a consultant gynecologist at Billroth Hospitals, Chennai. She has won the Johnson Medalist in Madras Medical College. She has field of interest in laparoscopy. She has won the Best PG Paper Award from Oxycon 2010 and she did her fellowship from Paul's Hospital, Kochi. Our very own consultant, Dr. Madhumita. She finished her MBBS in Government Stanley Medical College. She did her MSOG in Government Theni Medical College and she did her senior residency in Ramachandra and she finished her fellowship in Saimar. She is a member of ISAR and she has published various national and international articles. May I call upon the next speaker, our very own consultant, Dr. Aparna Das. She finished her MBBS in Sri Balaji Medical College and MSOG in Narayana Medical Hospital in Nellore. She finished her fellowship in Ramachandra Medical College and she is a gynecologist and fertility specialist in A4, Tambaram. May I call upon the next speaker, our Chief Clinical Excellence Officer and anesthesiologist, Dr. Ram Kumar. He is invited as a faculty in the Airway Conference and Workshops in Malaysia 2016, Dubai 2017, Abu Dhabi in 2018 and other national and state conferences. He is a member of Organizing Secretary of RALS and RACE. He has various publications to his name. And special areas of interest is airway, pediatric and obstetric anesthesia. The last but not the least, our very cute and today's MC, Dr. Mohini, our consultant from Virugambakam. She finished her fellowship in Dr. Nagori's Institute of Infertility and she finished her MSOG in Savai Mansingh Medical College. I now call upon Dr. Osama Shawki sir. And let the session begin.
Good afternoon, sir. We've had a very nice day of discussion about hysteroscopy with all the simple beginners level to the most complicated one where you yanked out one from the abdomen into the hysteroscopy purview. So we just had some few clinical points to stress on, like what all complications we could expect and to know from the expert.
You can give the
Actually,
slide
I reviewed the slides in the morning and I promise you they chose the best topics, really, and the most debatable that you must know about it. So don't leave and stay.
But you have already covered everything, sir. Now we don't know what to ask for.
No, it's the same slides that the reverse panel that you...
Yeah, the same slide.
So they cannot play it?
Yeah.
There is more and more to
Thank
get
you.
from you.
Thank you. You are from Chennai?
Yes, sir. I'm Dr. Kritika, sir.
Yeah. Because I have a friend, her name is Malvika Mishra. You know her? You don't know Malvika Mishra? Yes. From Indore. She looks like you. I thought you... I don't forget any faces at all.
Addressing and avoiding potential concerns, reverse panel discussion. So we all are very lucky to be sharing the stage with you and having this reverse panel.
I'll hold the mic for you.
We're going to discuss several topics. We're going to start with a very basic and yet a very difficult topic, and that's difficult insertion. Sir has already discussed about this, but let's have a case scenario. A 27-year-old woman married for 4 years, anxious to conceive. She has a history of 2 chemical pregnancies. She's posted for diagnostic hysterolaparoscopy. On speculum examination, her os appeared pinpoint. So pinpoint os is one of the scenarios which we face. Another difficult scenario we face is acutely anteverted uterus despite a full bladder, and also anteverted retroflex uterus. Next slide. So we would like to know in which clinical scenarios difficult entry of hysteroscope can be anticipated. What are the precautions and preventive measures? How to negotiate an unexpected difficult entry? And will excessive cervical dilatation cause cervical incompetence in the future? Have you experienced any cases?
Well, I think that I already highlighted this in some of the slides. You have three stations of during insert, three stations which could be the external os, the cervical canal, and then the internal os. The external os is not a big deal, all right? You can use the scissor to dilate, or you can buy the dilators. You dilate only the external os. Don't go further. Don't push further, because if you go by the dilators, you'll do scratches in the endocervical canal, and you have these floating shreds, you'll not see well. The second problem is the cervical canal. Sometimes it is corkscrew twisted. And many of the cases referred to me from IVF centers, difficult embryo transfer, it's not because of stenosis, because of direction. What I suggest is that you dilate the external os to insert the smallest diameter sheath you have. We know that the office length is 2.9. It's assembled in inner and outer sheath. So use only the inner sheath to avoid large diameter, okay? And go from external os, stay and open the pump pressure to the maximum. Don't be afraid from any fluid overload now. There is no absorption. And also the uterus will not explode, okay? Use the maximum pressure to dilate the cervical canal. And sometimes there is mucus inside. And if the external os is tight, there is no drainage. So go in and out, in and out, in and out. You clean and go out, in and out from the external os, until you have a clean cervical canal. And then try to find a clue from the internal os. And you do what I showed by the scissor to dilate. For the anteverted uterus, usually in any laparoscopic surgery, we evacuate the bladder before. But in hysteroscopy, don't evacuate the bladder. We prefer to have the bladder full. Mostly the uterus is anteverted, so hands should be down. Sometimes the insertion is vertical, like this. Can you imagine? So the patient buttocks should be pulled to the edge of the table, so you can have the chance, the space to move hands down. All right, and always glide on the anterior wall. If it is retroverted uterus, you have to stand up, okay, and hands up, and guide your telescope through the internal os. Sometimes the fluid pressure is enough to dilate. Sometimes still it's very narrow. But once you have a clue, seeing that, okay, then close your eyes, have courage, and push. Come on, how can I do this? You're already doing this every day with the Heger, okay? With the Heger dilator, you're doing this every day, but you don't see. But because you are seeing, you are afraid. But once you have a clue, push. And today I did it in three cases. Have you noticed that? In many cases I pushed, and happily I was inside the cavity. So this is how to overcome using misoprostol is not nice. I don't like it at all, because misoprostol makes the cervix soft, not dilatable. But yesterday Dr. Shankari told me that you have something like gel, you put it in the cervix, hygroscopic. Divya was telling me about. No, but Divya told me something different than laminaria tent. Laminaria tent I know, but she told me this hygroscopic gel, you put it just into the cervix and it swells and opens the cervical canal. So this is all you can do. No, there's no role for any misoprostol or pessary.
I think that's the Dilapar, some pessary which they've come up, which we can put it inside the cervix and it
inside the
dilates.
cervix. Okay,
Inside
so probably
cervix.
this one, yes. I don't know about it. First time I know here, yeah.
So next is a case scenario. A 46-year-old woman, married for 23 years, primary infertility. She was planned for donor egg program with nil AFC. Her scan suggested UCL of 4 centimeters. She was posted for diagnostic hysteroscopy. Despite ultrasound guided introduction of hysteroscope, there was a posterofundal wall perforation with the visualization of the loop of bowel. So our question is, how could have this been prevented? How do you tackle this situation? In this kind of situation, what do you anticipate? How do you anticipate the risk of perforation? How do you perform chromopertubation after uterine perforation? And do you suture the perforation?
Well, we have to differentiate between different types of perforation. Perforation by the office diagnostic hysteroscope, or by the scissors, or perforation by the resectoscope, or by the mechanical devices, the morcellators, okay? Well, perforation by the office or the scissors, completely safe. Even don't put the patient under observation, perforate and send her home immediately. No problem in that. And actually the scissor diameter, the scissors, is the same diameter like the ovum pickup needle. And the IVF people, they know that sometimes when the uterus fixed RVF, they reach the ovary trans uterus. So they puncture the uterus with it. So the scissor is the same. No worry at all. I tell a little story, secret. In the early times, I was younger and I was invited to do workshop in Europe. And I was not good as now, okay? And it was a case of short septum. So, you know, I was a little bit excited, people watching me, and the internal os was narrow. So I tried what I did today, to push. And then when I pushed, I saw the bowels and the omentum. So immediately I pulled back. Nobody noticed that, right? Nobody noticed that. But my assistant said, "Sir, what is this yellow thing?" Okay, nothing, okay? And then I adjusted my hand down. I could see the internal os. I was relaxed. I entered the cavity. I finished the septum. And the patient went back home after 1 hour. It was office procedure. She was awake. She said only ouch when I perforated, okay? And then nobody noticed that, all right? So this perforation is absolutely benign. But perforation by the resectoscope with electrocautery, if it happened, you ask me how to prevent this. It's very easy answer. Never do any step without vision. But Osama, you are going through adhesions without vision. This is the expert sensation. Okay, so you develop this after a long time. But for 10 years from now, never operate without vision. Like the good car driver, he can drive in the fogs, but not you. You should have a very clear view. So you will never perforate if you see well. But if you perforate by the resectoscope and you recognize this at the moment, no need to do laparoscopy. But if you kept playing for some time and then you realize, oh my God, this is the bowels, you have to do laparoscopy. The mechanical morcellators, they promote it as very safe. It's not as safe. There is 2 cases reported in US morcellating the bowels. So the key of safety in hysteroscopic surgery, do no harm by always having good vision all the time. That's it.
So this is one case where we perforated the fundus, but there are sometimes when we do a resection, when there is an anterior myoma, we continue resecting and we perforate a little anteriorly at the level of the bladder. The bladder also is full and it's a previous cesarean. Then
the only dangerous perforation is the lateral wall. I hope tomorrow, remind me, I'll show you a video tomorrow that somebody was doing lateral metroplasty and he was cutting, and suddenly something like a snake herniated into the uterus. The uterine artery, but not injured. The uterine artery skeletonized. So, but if you hit the uterine artery, the most 2 dangerous complication of perforation, lateral wall and the cornea. But anterior wall, I have seen it only once, but not by the resectoscope, by the office hysteroscopy, and it was in AISUG in Kolkata. Okay, I will not say the name, but somebody was going through a very narrow cervix, and the patient had previous 3 cesarean section. So perforating the cesarean scar and into the bladder, and even they didn't recognize this for about 1 minute. They thought that this is the uterus. Okay, and then this anatomy is not the same. Oh, this is a tubal ostium. No, this is the ureter. Okay, sorry. So no risk from anterior wall or posterior wall perforation. No, it's only the fundus and the lateral wall.
So now questions on septal resection. So there is a case scenario, sir. She's a 32-year-old primary infertility patient. Her HSG showed the similar picture which you showed. It's a complete septum.
Yes.
With patent fallopian tubes, and her AMH was normal, and spouse had severe oligospermia. So ICSI was done and 4 blastocysts was created and frozen. Patient was anxious, hence we resorted for septal dissection. And what is your opinion on doing laparoscopy for all the cases of hysteroscopic septal dissection? Is it really needed for all the cases? And how do we maintain the right plane of resection, especially when we are handling 30 degree or 12 degree scope? What are the crucial points during the procedure at which you will be alert for not perforating the uterus? And how to prevent the same? Just share some tips and tricks. And another scenario is a case of complete uterine septum extending till internal os with vaginal septum.
Well, I think most of these points have been covered
Yes.
today, but let me elaborate more. I repeat, there is no any value or need for laparoscopic control during septum, because I say that the laparoscopic person will help you very well to perforate. He will guide you to perforate, because he will keep giving you, allowance, okay, reassurance, come on, and stop, because he sees the transformation of light. You're on the serosa, so it doesn't help at all. The only way to judge when to stop is inside the uterus, when you finish, when both tubal ostia at the same line. Sometimes you cut a little bit here, a little bit there. It's a plastic surgery, okay? Using ultrasound might help, but this means that you're not expert in septum. You should not do it, okay? Yeah. You do it when you are, even, how can I develop my skills, Osama? If every time you say, don't touch when you're young, keep somebody next to you to tell you, no, you can cut more, or stop. This is the way to learn in hysteroscopy, okay? About perforation, sometimes when you reach near the fundus and you didn't cut and suddenly find the fundus, puck. This is the effect of fluid. So what I advise you, the more you climb up, decrease the fluid pressure. Okay. There are too many things to decrease the pressure, either to open the outflow or to decrease the inflow. Again, playing with the fluid in and out is one of the very fine art in hysteroscopy. Nobody is teaching that. That's why I said people don't have my vision. I play all the time by the in and out. And sometimes you were with me in the operating room, I was holding the cable, the water, and I was kinking it. Yes. So this is to control the pressure. Sometimes the perforation happens by the pressure of water. So nothing called residual septum. Residual septum means you didn't do it correct from the start. All right. The second look, I do routinely in my practice. Second look, ultrasound, 3D ultrasound. If you do the ultrasound immediately next cycle, you will see the septum as it is. Okay. Yes, although it is corrected, because the scar of the septum is hyperechoic. So the septal scar appears as if there is a septum. All right. And actually, I just see a case before I come. She did septum surgery with somewhere else. And then she did the ultrasound after, and they claimed the previous surgeon was very bad. The septum is still there. She was referred to me. I did second look. There was no septum inside. So probably he was mistakenly blamed for that. So give it 3 months to assess by ultrasound. If there is a residual part, I can do it by the scissor. No, I repeated this several. There's nothing called 2 settings. 2 settings means incomplete.
There are some people who say like a bigger septum, you do it in stages.
That's make them angry from me.
That's what I wanted.
I always say, don't start a job that you're not sure you can finish it. Okay, you cannot do laparoscopic myomectomy. Have you heard about laparoscopic myomectomy in 2 sessions? Okay. That's thing like that. So when you start, either you are competent or let somebody competent stand next to you. Incomplete surgery happened for many reasons. Mostly when he starts to cut in the upper part of the septum, some bleeding happened. And he doesn't compensate by increasing the pressure. He cannot see well, so he stops.
So the best is to finish off it in a single session.
So it should be. And sometimes, very rarely, I don't finish it. I confess to the patient, it is my mistake. There's nothing called 2 sessions. I didn't do it well from the start. But not everybody is honest to say that.
That's a very valid point that you have clarified. Thank you. So next is about clearing of the adhesions, what we see inside. This is a case scenario of a 41-year-old female where we had gone in to see, because there was a refractory thin endometrium all the time, but when we went in, saw a band inside. So how to go about it is a question, whether you cut the band in the center and leave it, or we have to excise together from the top and the bottom portion, and what should we do to prevent recurrent adhesions?
Well, so some people think that this adhesion should be removed. No, you just cut. Because these adhesions have in its contents some of the weak endometrium, one of the poor endometrium, thin atrophic endometrium. So we want to leave it for further regeneration. So don't excise. And the most important question you should ask me here in this issue, can we use the resectoscope? Because I see many colleagues, they use the resectoscope to cut into the walls to expand the cavity. This is absolutely wrong. Because those patients have very poor little endometrium. The resectoscope will destroy whatever little she has. So it should be only mechanical scissors and only cut. The post-operative regimen, we put the Foley's balloon. How many cc's we inflate? Under vision. You have seen me today? You have seen how I put the balloon or not?
Earlier I had seen, sir.
Yes, okay. So you put the balloon, you readjust it and inflate under vision. There is no number to tell 2 or 3 or 4 cc's. Every cavity differs in size. Also, I want to comment also for Mala Rajmi said the setting of the diathermy for myoma is 120. There's nothing called 120/60. No, nothing like this. It's changeable. It differs from one case to another. So usually you put the amount which inflate the balloon and keep the walls away from each other. If you inflate it blindly, you might put much more fluid. The balloon is stretching the cavity. As soon as the patient wakes from anesthesia, she will not tolerate. She will scream, remove it. And if you put less amount, it will slip. So the best way is under vision to put the amount necessary to keep the walls separate. Other adjuvant methods, we give, sometimes we try the amniotic membrane graft. We take fresh amnion. I schedule those cases while I have a cesarean section the same morning. I take the amnion and then we prepare it by certain way, by saline and antiseptic. And we take a small piece, we wrap it over the balloon and we put it inside. Some cases have good results. You can find a very nice endometrium. PRP injection, stem cell injection, intrauterine device are all options. Post-operative, estrogen and progesterone for 3 cycles. The balloon is left for 10 days maximum, and to remove it, in the same day of removal, you do hysterography to assess how much cavity created and to impress the patient before and after, like you have seen. Before you were 0, now you have good cavity. But we honestly tell the patient that the size you see now will shrink a little bit. So definitely we'll have a second procedure. This is the only intervention you can do second, third, and up to 6 times. And every time you release more adhesions and repeat the same balloon. And the balloon after removal, we might insert it blindly after 2 weeks or 1 month. So intermittent balloon insertion helps to keep the cavity expanded. And I tell the patient and her husband, the same like if you want to keep your shoes for storage. We put inside some papers, magazine papers, to keep it inflated. So this is all about the intrauterine adhesions.
Thank you, sir. Very valid point and very practical.
Thank you very much.
Thank you.
So can we do a relook hysteroscopy after adhesiolysis after 10 days?
But there is no value.
If the HSG shows a narrow cavity, if you want to again do...
No, if after 10 days a narrow cavity, you tell her there is another second step, not relook. Second step, but after 1 month. I forgot to add also, now we use the gel, intrauterine gel. There's many brands. I'm using one now. It's very, very convincing. When you put the gel in your hands and you make like this, it doesn't fall off. It stays for about 10 days. So this could make a layer to cover the lining and prevent opposition of the uterine walls.
So after 1 month?
1 month, yes. And I always say that the intrauterine adhesion, the first attempt should be done by the best surgeon. Okay? Because if the first surgeon was beginner, he will create multiple false tracks, so when I go after him, I get lost. And also, many of the colleagues, they underestimate the difficulty of Asherman. I met one of my colleagues this morning, and he said, "Sir, I'm very impressed, fascinated by your work. I follow all your videos, but I'm not as good as you. I don't do these big cases. I just do some little Ashermans." I said, I wanted to kill him. Okay. He chose the most difficult. I can accept you do myoma, but not the Asherman. Okay. Is Musil, yes.
We have a 34-year-old patient who's already had a cesarean 3 years back, sir. She's come with secondary infertility. Multiple cycles of ovulation induction has been tried, and there was a persistent significant fluid collection in the cavity. So there was an isthmocele around 7 millimeter by 3 millimeter over there. Would you correct it? And would you correct it laparoscopically or hysteroscopically? I know the definite answer. How do you oppose the edges if at all you do laparoscopy? And are we going to suture it? And are we going to check the integrity later on? And how do we check the integrity?
This is the most important issue we discussed today. Not because I want to teach you how to do ismocele, but to teach you how to do cesarean section. Osama, come on. Are you going to teach after all that years? Yes. I am revolutionary and I will convince you. Number one, why ismocele occur? Number two, there is no treatment for ismocele. There is no. Whatever I do by hysteroscope, this is not a treatment of the ismocele, it's treatment of the symptoms of ismocele, but it will stay. As she will show you in my videos, all cases of ismocele that I operated, when I go from the cervical canal, just at the end of at the cervical edge, here I find the cesarean scar. The cesarean scar in the cervix. In the cervix. You have the picture, and the internal os above. So the problem of ismocele is that because the cesarean section incision is very low. So what I'm revolutionized, instead of teaching the youngsters in cesarean section, dissect the bladder and go down, down. No, go up, up. Just at the junction between the upper segment and the stretched lower segment. How to know that? This is the visceral peritoneum, okay? Loose, loose, here is tight, okay? I will cut here. From now on, this is the way to do cesarean section. Because when you dissect down, actually after healing and the lower segment shrinks, your incision in the cervix. And many of the ismocele I found in the cesarean scar, Nabothian cyst. Nabothian cyst, so it's cervical. And in the video she's showing, I gave her, no, this is why bleeding happened from ismocele, because in this area it's defective of muscle fibers. And we know that any bleeding from the uterus, the hemostasis depends on myometrial contractility. Here there is no myometrial contractility, as you see. So this is all bleeding, and it continues to bleed. We have to cauterize this. Please show the next video. Okay, play. Why it's not playing? In this video, I show you the proof that the scar of cesarean section is in cervical tissues. So laparoscopic procedure, they excise that defect. It is a pouch. They excise that and suture again. You suture in the same weak area that is defective of myometrium. It will herniate back again. And I have the proof, many cases done laparoscopic repair, and the ismocele is still, the pouch is still there. So, as I said, there is no treatment for ismocele. The problem that the collection of mucus, as I told you, that scar, the cesarean scar, is in the cervix. So the cervical mucus collect here, make a thick viscosity with some blood. In my videos you show it very well. So this fluid regurgitates back into the cavity and makes fluid into the cavity, and IVF people are not happy. So what I do in this pouch, I excise the lower edge and sometimes the upper edge to convert this defect from a soup plate to a flat plate. Okay, so this will allow drainage and cauterize the endocervical epithelium. It's not working? Well, if they cannot, please, tonight before you sleep, you go to YouTube, Osama Shawki, and ismocele secret, ismocele pathogenesis. There is 100 videos which you can see the cervical epithelium in the cesarean scar. So the conclusion to that issue and the take-home message: make your cesarean scar incision as high as possible, not as low as possible.
Good evening, sir. It's good to be an anesthetist in an obstetrician fertility consultant forum. Thanks for giving the chance. Because anesthesia is considered as an enemy behind the lines. At the end of the patient, always it's an horror thriller film.
We cannot live without you.
Hysteroscopy especially.
Yeah.
How is your anesthetist, first of all? Is he good? Is he bad? So I think over the vast experience, you would have formed a very good team, sir.
Excellent.
So how is your plan? Your difficult cases. Do you have any strategy? So especially it comes to level 2 or level 3 hysteroscopy. It's a kind of a wide, it's the fit-led kind of.
Play it from the video directly, not from the. What I want to say about you that I can accept any anesthetist in my operating room, hysterectomy, myomectomy, but for the hysteroscopy, I should have my own anesthetist for hysteroscopy. The hysteroscopy anesthesia is different. Also, I don't know about India here, but in my country, when the anesthetist give induction, sometimes you go out of the room and to smoke a cigarette or to speak with his friends. I can accept that in hysterectomy, but not in hysteroscopy. I tell him, glue your feet next to the patient. Don't move. I finish in 15 minutes, don't move, because the complication happen in a second. There is no deterioration. If you have postpartum hemorrhage, there is a gradual deterioration. They can call him from outside, come back again. But here, the patient arrests in a second, all right? And I give in my hospital, I give the anesthetist the full authority over the surgeon. He had the right to pull out the electricity, stop the operation. Don't consume more than certain number of bottles and certain time. We had a patient died before I come because the surgeon insisted to finish a myoma and he took 45 minutes. 45 is fatal. And the anesthetist was alarming him, sir, you have to finish. I said, okay, no problem. Give me more 5 minutes. And the patient arrested suddenly. So, anesthesia, I tell you now some good advice for you. You stand at the neck of the patient and look here. If there is starting parotid swelling, tell him finish. Then jugular congestion, tell him you have 2 minutes. Then oxygen saturation is little drop, pull out. There it is. No, so these are the alarms. Can you play? Okay. I want to move the video. Give it to me. So this is the endocervix. No need. Let me sit here. Look at the endocervix. This video prove my theory. Okay. You see this dirty material coming from the isthmocele. This is the cervical epithelium. Okay, we are going on slowly. Look at this dirty viscid fluid which was collected in the pouch of the isthmocele. It's mainly mucus. It's mainly mucus, not blood. Okay? Now going in, this all endocervix. This is all endocervix. I'm cleaning the lens. Go out and go in again. You see how much collection was inside? Pause. Everybody look, the mucus was secreted from here. This is the endocervical glands. Okay? I'm going slowly. Here is the cesarean scar. Okay? And that's the edge of the cervix. So the mucus secreted from the cervix collect here. This is the, look, Dr. Shankari, look, this is the cesarean scar. It's a very obvious. There is a small septum inside. So let me now prove it to you. Here is the cesarean scar. And this is the anterior aspect, the cesarean scar. And here is the edge of the cervix. So the incision is very low at the level of the cervix. And the mucus secreted from here collect in this pouch. You see that? That's the isthmocele. So this incision should have been much higher. Much higher. Look at the mucus secreted from here and collected here. So this is proved very well the pathogenesis and the etiology of the isthmocele. Again, this is the cesarean scar. Okay, sorry. Here is the cesarean scar. You see it? This one. This is the cesarean scar. Here. This white line. And this is the edge of the cervix. You believe me now? That the cesarean incision was very, very low. Again, this is the cesarean scar. This is the isthmocele. And this is the endocervix. So the problem is because of the very low placement of the cesarean incision. From now on, do it high. against what we have used to teach. Okay. There is another video. Can you play it? No, the Nabuthian cyst. Okay. This one. This is a Nabuthian cyst in a cesarean scar. Can you see? This is the. Do you see it well?
Yes.
What else evidence you want from me? All right. This means that your incision was very low, very low. That's the approaching the internal os, and just above the end of the cervical epithelium, this is the cesarean scar with a Nabuthian cyst. Obvious? Next. That's catastrophic. That's the thing you don't want to see it. Venous gas embolism, yes. Anesthesia is here?
Yeah,
you should speak about that, yes. But before you speak, I tell you, an accident happened, so you take care from complication. I was operating in one city, and they don't have a pump. So they were using a pressure cuff on the bottles, all right? And it was a big myoma. I started to cut into the myoma and the big cavity, so the pressure cuff was not giving much effect to pressure to expand the cavity. And I was shouting the man behind me, please give me more pressure. And suddenly the pressure was very good. And I was very happy. I didn't know what he had done. All right, I'll tell you later, okay? And I started to cut. And suddenly pressure lost, bubbles, patient arrested. Everybody was panicked. And the anesthetist handled the mount. I said, what you have done? The bottle, plastic like this, and the cuff around. He raised the pressure, and that was not enough. So he punctured the bottle from above by a needle and connected this to the sphygmomanometer. So he was pushing air to push the water, and that gave me a very good pressure. But while I was operating, he was mesmerized watching. The fluid finished, and a bolus of air entered. Saturation 20, but she was saved by miracle, okay? So please don't improvise and try to put air in the fluid bottle, okay? You have any comment about embolism?
Yes, sir. Like this, we can prevent and can manage always. So there are a couple of suggestions we do. We don't want the fluid which should be hanging more than 1 meter above the patient table. So when you raise it, the hydrostatic pressure increases, and obviously when the BP is low, so the hydrostatic pressure is high, so there's a higher concentration gradient, so rapid amount of fluid or the air which is there can be sucked in or pushed into the venous system when there's a breach in the endometrium, so chance of embolism is very high. So immediate thing is you have to get the patient to supine position, reverse the tendon impact, don't get in supine position, deflate the uterus, keep wet gauze in the end of the start of cervix, then put it in the left durant, that's durant position, put in the left lateral, put in an IJV, try to suck major air. If you find, you can do ultrasound, you find pick up, there is a lot of air collected in the right ventricle or if it's entered the pulmonary artery. If so, put in an IJV line, suck the air, whatever you have, and increase the BP. So increase the BP, it prevents further absorption, and it tries to avoid further complications. It's an kind of miracle, as you said. Yeah. So I just always think about how to prevent it instead of having it. So just my question is, what height you keep? You keep it in higher, more than that, or you try to avoid?
All the things he said should be done simultaneously. To team working on this arm and that arm. And I remind you again, during myoma resection, don't keep going in and out by the resectoscope. Stay inside. And if you are using a pump for fluid, always attach 2 bottles. So if one bottle finished, the second one worked directly. So during change of the bottles, the air might come in.
And one thing is we don't check the tubings always. First you let out the air when you prime the circuit or the scope with the fluid. But we forget to check the patterns of the tube. There may be a puncture or a cut in the tube that may suck in the air. That's one of the cause back. Despite having a good connection, there is this air sucking. So you have to check the patterns of the tube. There may be a puncture in it.
Next.
So this is already discussed.
Okay. This is the last one. The myoma is the last one.
So we've been talking extensively about how the 2.9 helps us a lot, but a lot of us have broken the 2.9 mm scope. What to do to make it really safe and, you know, avoid the breakage of the lens?
Well, listen. The equipment of laparoscopy is very durable. Whatever time pass, okay, it is still good optics, good vision. Hysteroscopy, they are very fragile. The smaller diameter make it semi-flexible, okay. You all know that the telescope is like a sheath, and inside it is not only one length. There are interval of lenses, between them interval of air space, okay. And the quality of vision and the quality of the lens depends on complete sealing. There is no water to go inside, okay. So the 10 millimeter telescopes, they're very strong. It's very difficult that you can bend it, all right? But the 2.9 is semi-flexible. Sometimes if you put it in the table and you rested your hand over it, it will bend beyond your vision. You will not see it. So this bending will make leakage at the lens and the water go inside and it becomes foggy. Whatever you clean it, it is foggy. So the telescopes of hysteroscopy are 4 millimeters, the 4 millimeter, the 2.9, 2.7, and the 2 millimeter. The 2 millimeter, in my opinion, is useless. It's considered semi-disposable, all right? It doesn't stay or live for a time. What I suggest, the 2.9 and 4 millimeter. There is no answer to your question except the operating nursing staff should be very well trained and deal with the telescopes like jewelries, okay? Very gently, right? The 2 millimeter is attractive for you that is very small, easy insertion. No. The smaller the diameter is very flexible. It doesn't go well, okay? So I suggest that you use the 2.9 and 4 millimeter. I know that there is a wave now in United States to abandon the monopolar and in Europe. I am the only one in the world who's working monopolar. All my work was monopolar. It is not that bad. The only disadvantage that in monopolar you have to use glycine. So if you know how to finish surgery quickly, monopolar is good. If you are still a beginner and you will take more time, you can work with the bipolar. I'm not a fanatic like those or promoting for the bipolar. The fanatics of the bipolar say we should abandon the mono. No, there is a place for both of them. Both should stay. The plasma one that I use today, I'm still evaluating it. I didn't work much today with the first time I use it, but I think bipolar is safer and it will stay. The use of monopolar will decrease, but not abandoned. Not abandoned. Yes.
So this is a case of unicornate uterus.
I hate this picture. Okay. Unicornate is very small cavity, and here you are using electricity which burn. So the space you opened will heal by fibrosis and it will shrink the cavity more. Okay. I'm sorry if it's your work or somebody. This is the technique I advise. Okay. Sharpen the scissor. Go and this is the lateral wall. Cut. I want your opinion. Which is more clean? This or the resectoscope? Do you see well? I'm hiding the... No. Okay. So here, the tubal ostium is my GPS point. So you take it as a reference for the level. Don't cut up or down. Exactly. And then I cut this wall. And how to measure the distance you cut. How to know how many millimeters. Ultrasound, you have a cursor to measure. Here, when you open the blades, maximum, this is between 2 and 4 millimeters. All right? So use the blades at a measuring scale to know how much you cut. So this is about like 3 millimeter. 3 millimeter on left wall, another 3 millimeter on the right wall. So you have like almost 6 millimeter up to 1 centimeter expansion in the cavity. There's another video, can you play it? The healing after scissor cut is much better. There's another video for the unicornate. Yes, No, the other one. Not this one, the next one. Yes. This is, you can play the sound. This case was done in Dr. Malhotra Hospital. Can you appreciate where is the dual ostium? It's in the center. So that's a beautiful reconstruction. Put the sound. Sound is not coming? Okay. Because you could hear the voice of Dr. Jidip and Narendra, they were talking. It's okay. And actually in this case, can you appreciate the surface area of the new added white and the original endometrium? So can you tell me what I'm doing now? That's the subendometrial PRP. Okay? We inject, that will stimulate regeneration and healing of the... By the way, all IVF centers, they invite me to do it now. Even yesterday with Madam, I did maybe 7 cases, yes. Pardon? The same needle here. Yes. You injected subendometrial? Without Osama. Okay. Next. I was trying to find an excuse to come again and again, and to take me to Marina also again. Yesterday they invited me to a dinner at Marina Seafood. It was so delicious. But the first person to adopt me in Chennai was Dr. Shankri, actually. Give an applause for her. She is like, I will not say my godmother. I'm older than her, you know. I'm older in age. I am. I don't want to say it in front of them. Okay. I'm proud to tell people I'm old, but I behave like 25. I go to the gym every day. I'm in the operating room 12 hours. So long you have passion, okay? This gives you power to live and be younger. Okay. Let us finish now by this topic. So, okay. Yeah. Fluid overload. Okay, let me answer. Usually anesthetists insist to have good hemoglobin before surgery. For hysteroscopy, it's no matter, okay?
Absorption, then there is hemodilution, so hemodilution.
You're supposedly a good surgeon. He should not do this. One more point. Also, Dr. Malaraj talked about bleeding during hysteroscopy and after myoma resection. In my opinion, there is nothing called bleeding in hysteroscopy at all. Even if you see pumping vessels, leave it. Leave it. It will spontaneously stop. It is not more than the placental bed sinuses after delivery of the baby. If you look inside the uterus, although it's impossible to look, but if you imagine, you will find that big pipes pumping blood. And it stops immediately after uterine contraction. The same in hysteroscopy. You will get frightened by this bleeding, but it will stop. And I only recall one case. I like to tell stories. I was operating at the place of Dr. Sushila Sainai. You know her? From Jodhpur. Sushila. Well, so it was a big posterior wall myoma and everybody watching me, and I cut. After I finished, the myoma bed was very big. There was no bleeding because of the effect of pressure, of fluid. And after I finished, I just wanted to impress them, to show off. Now, girls, would you like to see some bleeding? Okay, sir. So I decreased the fluid pressure. Fountains of blood. Scary. I just want to show them I'm brave. They started to shout, oh my God, sir, what we will do? I said, come on, trust me, it will stop. I left the room. I went to have a coffee. Then a little doctor came. Sir, please come back. There is excessive bleeding. I said, come on, you're still young. Don't worry. 2 minutes, the anesthetist. When the anesthetist come, you have to expect tragedy. He said, sir, you better come back. We really have a problem. I went to the operating room. There was a flood of blood, like postpartum. And then my confidence was shaken, all right? I started to feel trembling. What happened? This is never happened with me before. And this will change all my concept about leave it, don't cauterize. So I said, okay, give me the resectoscope. I will go back again, try to cauterize. They said, oh, sorry, the resectoscope is in the sterilization. We don't have it now. I said, okay, I will manage as if postpartum hemorrhage by manual compression until the resectoscope ready. I kept like this for a few minutes, 3-4 minutes. And while doing this, I looked at the monitor to check the vital data of the patient. And here were the surprise. The blood pressure was 190/120. So I told the anesthetist, Come on, why you didn't tell me that? He said, sir, I thought it's none of your business. I said, no, it's my business. Because with this high blood pressure, there is no chance for the clotting mechanism. I will not remove my hand until you decrease this blood pressure. After a few minutes, blood pressure came down. I removed my hand, dry. Not a single drop of blood. At that moment, the nurse came with the resectoscope. Sir, we are ready. What should I do? Should I go in again? Never. Never, because the hemostasis happens because of the contraction. When you go in and you distend the uterus, you dislodge the clots again. So this is the way. So no need to do hemostasis at all, unless sometimes during septum or myoma resection, I find a bleeder, I just cauterize to able to see well, because little bleeding will stain everything red. So hemostasis during hysteroscopic surgery depend on the power of tamponade of high pressure and sometimes individual cauterization. General spinal anesthesia is excellent for beginners. Why? Because the patient is awake and he will realize immediately the early manifestation of fluid overload. The patient starts to feel vomiting. I have nausea, then dazzling, I cannot see well, and then she starts to have a hallucination. If you don't stop, then you will not listen to her voice anymore, okay? So this is the, okay. Immediate post-operative pain, there is no pain at all. Missed IUCD, please, all this, go tonight to YouTube and write whatever you like, okay? Even Osama Shawki and Miracle of Life, FOGCE, you see the embryo inside. Missed IUCD, tomorrow remind me, I will show you a video. This is one, you see it once in your lifetime. Never happened in the history. I think, ma'am, I showed in your place. Intratubal IUCD perforating through the tubal ostium. You see only the threads. And I'll show you tomorrow how we can pull it very nicely. So the more skills you have, you can play whatever you like with the hysteroscope. So misplaced IUCD, so long I can see a clue, the threads or part of it, we can get it out. The last thing I speak about before we leave, how you suspect malignancy, it's unmistakable. You should stay more time with me. I give you more lecture. I have so many videos. When you see it, it's malignant. It's very obvious. Increased vascularity, fragility, necrotic tissues. It's very... The only thing that looks like it is retained product of conception. Okay, but there's a positive history of pregnancy. The last question you should ask me, what is the risk of spreading malignancy during hysteroscopy? Okay, because there's endometrial malignant cells and the fluid pushed through the tube. The literature confirmed beyond doubt there is no any risk. Even spread of malignant cell through the tube intraperitoneal does not implant and grow again and does not affect the staging and the grading of malignancy. So there is no any fear that you do hysteroscopy with a possibility of intrauterine. Hysteroscopy is not as simple as you think. Hysteroscopy is a new world. Although the abdominal cavity is bigger, but the uterine cavity has much more to do, to learn, to benefit our patients. Laparoscopic surgery in gynecology is getting limited and limited. Myomectomy now is abandoned by FDA. There is limit for that, okay? Hysterectomy. You should go to doctor in Ahmedabad. His name is, he teach you how to do vaginal hysterectomy in 7 minutes, all right? And evidence-based medicine say that the best route of hysterectomy is vaginal. You are brainwashed. You are driven by industry to sell for you harmonic and LigaSure. And the first introduction of laparoscopy for hysterectomy was by my friend Harry Rich. Harry Rich is a good laparoscopic surgeon. And I tell you, now what I'm telling you is secrets. He wanted to learn vaginal hysterectomy, but he was very bad. He didn't know how to do vaginal hysterectomy. So he thought to make it easier by releasing the upper pedicle. That's why the name of the procedure was laparoscopic. So it was vaginal hysterectomy. The aim is to do vaginal hysterectomy. So I mean, but hysteroscopy is another word for fertility, for IVF, for bleeding, endometrial ablation. Hafiz invited me last month to give a course about endometrial ablation. No more hysterectomies. The uterus is a coconut. Remove the lining and leave her to go home with her coconut. Even if there is a fibroid. Tell her the fibroid is still there, but you will not have a bleeding. So, the last entertaining story I tell you that once upon a time in the 60s, in the United States, David Nichols, the chief of Massachusetts General Hospital, invited a doctor from India in the 60s to demonstrate vaginal hysterectomy. The name of that doctor was Purandri. Not the Purandri of today. No, Purandri of today is young. Purandri is older. Yes, very famous. He was a very humble man. He went to the hospital, they received him, and then they went to the operating room, and everybody was scrubbing. You know, he finished scrubbing Indian way, okay, quickly, and he went to start the surgery. By the time the American doctors finished scrubbing and went to the room, they found the uterus on the table. I swear, this is a true story. So the American said, "Sir, what have you done?" I said, "I finished." "You finished the hysterectomy in 11 minutes? He said, "Yes." And he told them, each and every humble young lady gynecologist in India can do vaginal hysterectomy. So the Americans were surprised. And David Nichols told me, "Sir, give me your hand. I want to touch your hand to get the blessings to be able to do vaginal hysterectomy." And Purandri smiled and said, "I'm sorry, it might be difficult for you to learn it. Your mother should have born you in India and teach you how to eat with your fingers and get the fine touch. So good luck for you. Thank you and goodbye."
Blessed to have the dance with you, and I want to thank Dr. Aruna and Dr. Ashok for doing this wonderfully.
Meanwhile, we would like to thank each and everyone and all the participants who stayed back even till 6 o'clock to finish the event. We hope you all enjoyed today's session. It was indeed truly magical experience of hysteroscopy. So tomorrow, before you're all leaving, just a minute, please bring the badges that will have the barcode to enable you have the tiffin and lunch. So please bring your badges without forgetting. We start the breakfast session at 8 o'clock. So whoever has enrolled for the breakfast session, come at 8 o'clock, and 8:45 sharp we will start the lectures. Thank you all.